Uh, Hello, everyone. Good evening. So I welcome you all to today's research seminar. Today we have with us Professor Dong, who is an associate professor of marketing and business analytics at Santa Clara University. Professor Dong received her PhD from Northwestern University with an MS from MIT and BS degree from Tsinghua University in China. Dr. Dong's current academic research studies individual customers, consumer or business responses to firms' marketing efforts, and how firms' marketing strategies can be adjusted when taking this information into consideration. Her research has covered a wide selection of industries, including pharmaceutical, high tech, and retailing. We are very happy and delighted to have her with us today. And without further ado, I would request Professor Dong to please share her insights with us. Thank you.
Thank you, Anuj. It's a great pleasure to present here. So this is the current paper. I'll be happy to share the working version of the paper if anybody interested. So it's called Comparative Messages, Learning and Forgetting, Evidence from Pharmaceutical Drug Detailing. It's a joint work with my friend Yingxie and my advisor Pradeep Chintagonta of University of Chicago. So the study, the empirical context is we're looking at how pharmaceutical companies are detailing to the doctors. So pharmaceutical marketing has been really high. It spent a lot of money on marketing, and the majority of these spending is sales reps visit to doctors. So when a sales rep visiting a doctor's office, sometimes they deliver a lot. They deliver different kind of messages. One type of message is that they just talk about how great the drug is. The other type is that when they compare, saying that this drug, my drug is better than the competitors. So we have the information about how sales reps is communicating with doctors. And we also have detailed information about each doctor's prescription decision and their exposure to these different types of messages across competing brands. So we know that different companies are doing the similar things, comparative versus non-comparative messages to each individual doctors. So in the market that we are looking at, this market has one incumbent. So this drug has been around for a while, and then there were two new drugs entering the market. So this is a context this is the context we are looking at. In this data, we do not know what exact message the company are using for comparative or non-comparative messages. We only know that which drug they talked about or which drug they compared with. So in this context, in marketing, it's common knowledge, and there have been a lot of studies looking at comparative advertising in new product adoptions. And usually what we know is there's new product enter the market, is the new entrants usually can leverage the comparative messages to help consumers, to help customers to learn about the new drug, the new product, especially compared to the existing ones, and helping them to get their name better known. But usually what happened to the incumbent is that they try to avoid comparing their drug with a new unknown product. So that's the common knowledge that we get. But however, in the data, what we see is that both the incumbent and the new entrants are engaging in a similar amount of comparative messages. So this attracts our attention, and we decided to ask the question why that's the case. So it's specifically why such incumbents are still using this comparative messages in this new product entry. So we came up with these two. We basically combined the literature in the two areas and trying to explain why incumbents are engaging in comparative messages. So the first theory or the first line of literature we're looking at is the idea of signal jamming. So the signal jamming idea is that the customers, so in this particular case, the doctors, are learning about the new drug through the messages from the new drug's sales rep. And so the incumbent is trying to jam or interfere with such learning from the doctor's perspective. So the incumbents provide information through comparative messages to jam and interference with the learning of the new drug. And so in this case, so in our model, we try to incorporate such interference into a consumer learning model. Now I'll show you the details how we capture that. And the other thing that also documented in the literature is the forgetting effect. People learn about something and then over time they forget about it, or they forget about what they learned up to now. So the idea is, although the incumbent is quite known to the doctors, but the doctors we are looking at in this data are primarily all primary care physicians, meaning they take care of patients from all different kinds of disease. So as time goes by, they probably have forgotten some part of the learning they have done. So in our model, we try to incorporate this forgetting effect as well. And I'll show you how we do that in the modeling part. Okay, so just to give it in a nutshell, our research in this study, we try to understand two main areas. So one area is we try to understand how comparative and non-comparative messages influence doctors' prescription decision through the perceived informativeness and persuasive responses. And this is through sort of a regular type of modeling. And the other part that we are examining and focusing on is what's the role of comparative messages, especially in trying to explain why incumbents engage in so much comparative messages efforts. And so we incorporate this through the learning part of the model and by incorporating the jamming and forgetting effects into the learning model. So this is sort of this study and our model in a nutshell.
Xiaojing?
Yes.
Can I ask a quick question?
Sure.
Chirantan here. Sorry about joining late. So do you have a sense that pharmaceutical firms are probably spending like 20% of their sales on pharmaceutical detailing and DTCA, right? And out of that, do you have a sense of how much are the splits in these different types of mechanisms? How much is like jamming kind of activity spends? How much is forgetting kind of activity spends? I don't know whether you already, okay. So you have already, can you?
I don't have the, okay, let me back up a little bit. So I should basically, so here's an overall number, about 60% of the marketing expenditure is on sales detailing. And then in the data, I'll show you in a minute how much the company spent on comparative versus non-comparative messages. So in general, it's about 15%, somewhere around that. Yeah, but I'll show you in our data.
Got it. Okay, thank you.
Thank you. Okay, so let's get into the data modeling. Again, this is a small group. It's really cozy and nice, so feel free to ask me any questions anytime. So the data is, as I mentioned, so this is, we have a national panel of primary care physicians. So we have about 6 years of the data and from 2003 to 2009. So in this time period is interesting in the sense that, in this product category, we're looking at the ED category. So in this category, there was a, very famous, very successful incumbent drug, which is Viagra, which entered the market in 1998. So by the time we have the data, the drug has been really popular for 5 years. And then during the period of this time period, there are 2 new drugs that entered the market. So Leavey and Cialis both entered the market in in 2003, and they are only 3 months apart. So it's a great setup for us to understand the incumbent and new entrants relationship and how drugs are being adopted by the doctors. So we selected a sample of 400, about 500 physicians. So because we are making sure we want to study how they learn or adopt a new drug. So we selected only those doctors with at least 3 prescriptions during the 6-year period. So there are about 14,000 prescriptions. And in addition to that, we observe all the detailing activities from all the 3 companies within this category. So there were about 36,000 detailing visits, and we know which drug was that, which company is sponsoring the sales visits, and we know whether the message is comparative or non-comparative, and we know which drug they are comparing with. So that's sort of the, the data is a physician panel with some detailed messages and information about prescription they write and detailing visits they received. Okay, so we also have some information about patient characteristics. We have very limited information about patient characteristics, primarily because the data collector is trying to protect patient privacy information. So we only know whether the patient has a very severe condition, and we also know how they pay and their insurance status. So here's the information about the comparative messages versus non-comparative. So here's the total detailing. We have 3 drugs. The total detailing is about 11,000, 12,000 for each drug. And the comparative detailing message is around 15 to 18%. But one thing to notice is that this percentage is quite similar, because as I mentioned earlier, in the knowledge of marketing yearly, we would expect the new entrants will engage way more comparative message comparing to the incumbents. But they are all comparable. Here's the last column is the prescription market share. And by the time we are looking at the data, all 3 products are in the market. 2 of them are relatively new. But Viagra, or the incumbents, is still the one with the highest market share. So
one quick question on the
yes.
data. This is, so 35871 is all, this is US data, right?
Yes, this is all US.
And so 35871 would be the number of detailing visits. That's the unit of observation.
That's right. Yes, that's right. We have every single detailing information. We have every single prescription information. Yes.
And that would capture all of US visits in this ED category, or what percentage of that would this be?
Oh no, this is a selection of physician panel, because we are only looking at about 488 physicians.
Okay.
So we don't have.
So do you know like what percentage of the universe it's capturing?
I don't, but I think there are. I've seen a lot of like industry reports about the total detailing spending and total detailing size. So if we look at that number, we may be able to get a sense of this. But this is a panel. Yeah.
And during this period, Viagra loses its patent, right? Pfizer focuses on China as well in the market. There's a famous Pfizer Viagra case that I teach and others teach also, that basically tells you that closer to its patent life expiry, Pfizer starts diverting its sales from US to non-US markets, especially with a focus on China. And then there are trademark battles that happen. So are you covering that period? Do you know whether any of these drugs lose a patent during this 2003 to 9 period?
I don't think so. I think so. 2009 yearly, yearly is about 12 years, right? So by the end of the data period, we may run into that, but I'm not aware of that. But that's a very good point. So I should take a look and see whether that has some impact on this.
The reason I ask is like institutionally, I'm just thinking if I need any of these ED drugs, do I need a detail? I'm like a physician prescription. Can I go and buy from the black market or somewhere some fake Viagra or some alternative to Viagra being parallel imported back to US from some other location and blah, blah, blah. So like how critical is this in the choice that physicians are making in writing their scripts? That's what I'm trying to get at. But it's okay. I mean, I probably will come later when you do the results. So you can defer
Yeah,
this
yeah.
question
So,
later.
so one thing is I'm not aware, you know, how black market behave in the U.S. during this period of time.
Mm-hmm.
So I'm not familiar with that. I'm not also either. I think in my understanding is uh, this market back in those years, is
Mm.
the black market's impact is probably not as big as later on. And this is still relatively early in the market. But again, I don't have the information. It's just my sense, my guts tell me. But that's a good point to see whether that had any impact on these decisions.
Okay.
Okay, thank you. So let's see. So okay, so here's the utility function we are looking at. So basically, we are looking at the decision of the doctor when there's a patient coming in at time t, and the doctor D will have to decide which brand of drug, which brand among the three drugs the doctor needs to prescribe to the patient. So the utility function contains these following parts. So the first thing is the doctor's belief about the quality of the drug, especially at that time, because remember our data covers 6 years of period, and two of the drugs are new, so doctors are learning about the quality. And this is the patient learning part. And then we have the regular patient information, and we want to look at the comparative versus non-comparative messages in terms of the persuasive effects of these drugs in persuading doctors to write prescriptions. And then the error term, it's a logic error term. So the main part I want to talk about is really the learning part. So doctors, over time, the doctors are learning about the quality of the drugs. And so the process is like this. So at the beginning of the whole data, we use the first month's data and to derive the prior. So the doctors believe the drug's quality follows a normal distribution, and so we call it a prior. That's the prior distribution. We identify the prior distribution using the first month's of data, and we can calculate the mean of the prior normal distribution. And then, so in that, because we only know the relative quality, so we fix Viagra's prior mean quality as 0. And so that's the prior. As time goes by, and doctors started learning about the quality of the drug, especially only on the new drug. So doctors did not learn about the quality for Viagra because it's the incumbent, and we assume they already know. So when they learn about the quality of the new drug, they look at this through patient feedbacks. So if for a doctor who has prescribed a lot of these prescriptions and seen a lot of patients, they know better about the quality of the drug comparing to relatively newer physicians. And then that's patient feedback, and then through the new drugs detailing. So the doctor wants to learn about Leavetra's quality. For example, Leavey sends comparative messages and non-comparative messages to the doctor, and doctor can learn from these two different types of signals. And finally, when the doctors are learning about the new drugs, especially for Leavey and Cialis, their information coming through Viagra as well. Because when Viagra is comparing, Viagra's sales rep came to that doctor's office saying how Viagra compares to Leavey and Cialis, that provides information to doctors learning about these two new drugs as well. So these are three sources of learning that we are going to capture. Okay. Then the question is, how do we incorporate the signal jamming and forgetting effects into the learning process I just described? So if I can put it in a timeline, so suppose here's at t equals 0, each doctor has its own prior distribution about the quality of drug J. So J could be either the Leavey or Cialis, the two new drugs. And so that's a prior. And then when we come to time t-1, through Bayesian learning, the doctor already formulated a posterior distribution about the quality of the drug, follows the normal distribution with a mean of Q bar and the variance of sigma square Q. So, and as according to traditional Bayesian learning, when it comes to time t, the doctor has a prior distribution about the drug, and this prior distribution is exactly the same as the posterior distribution from t-1. So this is the Bayesian learning setup. And then by the time t, the prior is the posterior from last time period, and then it updates this distribution through the detailing visits, through the patient feedback, through all this information the doctors got between t-1 and t, and then they formulate a posterior distribution. So now the Q bar is, instead of t-1, it becomes t, and so the sigma square is, instead of t-1, becomes t. So this is the traditional Bayesian learning part. So to incorporate the idea of signal jamming and forgetting, so where's the jamming comes in, where's the forgetting comes in, is we incorporate through this between the t-1 and time t, right? So because between this t-1 and time t, by the time at time t, the doctor is trying to recall what they have learned through t-1, we assume that recall is not perfect. So the prior distribution is not exactly the same anymore because they need to recall what they learned. So now the mean becomes a Q tilde, and the sigma becomes sigma tilde. So these two are different as compared to the traditional Bayesian learning, considering these two are exactly the same. And then next slide, I'm going to show you how these two are different from this, these mean and variance. These differences are actually influenced by the signal jamming and forgetting effect. Make sense?
Mm-hmm.
Very good. So how do we do that? We create another variable called, we call it adjustment to A for index for J and T. So J is the brand and T is the time. And this adjustment variable is capturing the two effects, the jamming and forgetting effect. How do we do that? So here, if we're looking at, let's say, product J as Leavey, which is one of the new drugs. So Leavey's adjustment variable is captured by this M. This is the comparative messages. This C stands for comparative messages for Dr. D from Viagra. So basically, we look at how many comparative messages Viagra came to talk to Dr. D and say, hey, Viagra is better than Leavey. So this is Viagra's comparative messages comparing to Leavey, and this variable captures the jamming effect to Leavey's learning. And then we capture the timing effect. So this delta t is how long it has been from t-1 to t. Because the t-1 is the last patient visit. The doctor formulated all these posterior distribution for the last patient. And then now there's a new patient came in. How long ago was that? If the time was too long, the doctor already forgot a lot of things that they've already learned and has, so it has will change the prior distribution formulation. So that's sort of the formulation of the adjustment. And then, so the new variance for the recalled prior distribution is the original variance adding an additional term. This additional term is a function of the original one times this adjustment variable. And similarly, the mean of the recalled normal distribution is the original one, original mean plus a function of the A also as a function of the sigma from the original, and then we added a random term of normal distribution. So that's how we incorporate the jamming and forgetting effects into the learning part. So the jamming and forgetting effect is captured by this capital A, and then this capital A will influence the recalled mean and variance of the normal distribution. Okay, so that's the model, and there are a lot more details in the paper. So if anyone interested, I'll be sending the working paper. So here are some of the results. Let me show you. So what we find is this is the non-learning part of the estimation. So we have the non-comparative and comparative detailing estimate from the multinomial Logi model. And all of most of these parameters are positive and significant. And then one thing we noticed that comparative messages tend to have a higher impact in influencing doctor's choice than non-comparative messages. And so this part, what's the true quality of especially the new drug, is obtained from the learning part of the model. What we find is, because for identification, we fix the true quality of Viagra to be 0 because doctors are not learning about Viagra's quality. New drugs have lower quality than Viagra. Okay, in the other results I want to show you is, when doctors exposed to this information, like we call it learning signals. Every time they write a prescription, they learn something about the drug quality. Every time they receive a comparative message, they learn something, or non-comparative, they learn something. So each signal is considered to follow a normal distribution. And that normal distribution captures the true quality of the mean, the mean of the true quality, and variance of the signal. So here we capture the variance of the signal. We can see that comparing these 3 columns, so prescription, non-comparative, and comparative messages, the prescription signal has the smallest standard deviation. So that means the patient signal, when the doctor is writing a prescription, they learn the most, or they learn the most information about the drug quality. But when you compare non-comparative with the comparative detailing messages, we find that the comparative messages tend to contain more information about the true quality of the drug as compared to non-comparative messages. So basically, doctors learn more through comparative messages than non-comparative messages. Okay, and then here's the results regarding the jamming and forgetting effects. Remember, this part we incorporate into the capital A, or the adjustment variable, and that we calculated. So here we find that Viagra was compared by Leavey and Cialis. So when Viagra is, so the idea is when Leavey is comparing to Viagra and Cialis is comparing to Viagra, it does have some jamming effects, right? So the parameter is positive, meaning higher more comparative messages would lead to more interference to various learning. And similarly, we find that when doctors are learning about Levetira's drug quality, the fact that Viagra is comparing to Levitra also leads to the signal jamming effects for doctors learning about Levitra. And so finally, we find it's a forgetting effect. So the in terms of number of days since last time, I also all of them have positive significant estimates, meaning if the number of days since last time was really long, this adjustment variable is higher, and that interference or the losing of the learning is higher. Okay, so for the interest of time, let me skip the smaller comparison. So basically, we try to estimate some other models, and then I want to talk briefly about this counterfactual results. So one of the things that's unique in the US is that US is among the very few companies who are who allow comparative messages, and in other countries this is not allowed. So we run a counterfactual saying that suppose the comparative messages are banned, and what we find is the incumbents, if that's the case, the incumbents will benefit the most. So just to summarize, I think we are running short on time. So basically, we develop an individual level Bayesian learning model, and we try to understand the comparative messages and non-comparative messages in influencing doctors' decision. What we find is comparative messages are more effective than non-comparative messages. And this is true for both the persuasive and informative effects. And through the learning model, we find that comparative messages are also providing signal jamming effects for both incumbents and new entrants. And then we also find the significant forgetting effects. So some model comparison told us that if you ignore the jamming and forgetting effects, you will underestimate the true quality of the drug of the new entrants. And from the counterfactual analysis, we find that the entrants with we find that the incumbents is benefiting the most, and the entrant with higher quality will benefit also better, more than the one with lower quality. So, thank you.
Awesome. Thank you, Professor Dong, for the awesome presentation. That was really nice. It's a very close group, so we Chirantan had a few questions beforehand. I think he has one more question for you that's posted here, that might it be worth parametrizing the doctor heterogeneity? Do you have any?
I'm sorry.
Yes, please. Or Chirantan, do you want to ask the question?
Yeah. So it seems like your model assumes away clinician heterogeneity, but there is a lot of work.
We have that. I forgot. I didn't mention that. Yeah, we have doctors heterogeneity. It's hierarchical Bayesian model to capture that. Yes.
Okay. And my other related question is that if doctors are heterogeneous, the impact of jamming / forgetting will probably be different in the way they are prescribing, especially if a doctor is not able to tease out when a jamming is purely for a jamming purpose and when a jamming is for making you forget about the main drug on which you want to focus. So some jamming, so there's some confounding between a pure jamming effort on the part of firm strategy and a jamming such that the doctor forgets about the competitor's brand. How do you separate that out from your analysis?
Yeah, very good point. Yeah, we are not trying to separate out. So what we do capture is, so the identification is really through different X variables. The forgetting effect is purely from how long it was from last patient visit. So the idea is if a doctor, because we have the panel is only primary care doctors. We don't have experts. Right? So it's no specialists. The specialists, they tend to see more patients and more frequent. In primary care physicians, they don't see that many patients in this particular category. Like I think we pick the doctors only. So some of the doctors prescribe only 4 prescriptions over 6 years period of time. Right. So if a patient visit was 20 days ago, or versus a patient visit was 200 days ago, so the doctors recall of the quality they learned from last time will be different. So that's how we, that's the only forgetting we attribute it.
Got it.
Jamming
Thank you.
is only through the comparative messages. Yes, great question. Yeah. So one of the things I just wanted to point out is, I didn't mention is, for each of these estimates, show the, parentheses with, so the parentheses is posterior mean distribution of 2.5 and 97.5%. So it's a hierarchical Bayesian estimation, and these are results from the population level estimates. So we have individual level estimates. Yes.
Thank you.
Thank you.
Amit has a question.
Yeah, Amit. Please go ahead, Amit, and ask the question. Okay, maybe I can read Amit's question for you. So he says that finding talks about one therapy area. Can we correlate this finding to other therapy area? So as attribute differs in products of different therapy areas, can we be sure in validating this?
Yeah, so that's an excellent question. So we don't know. I think the methodology can be translated, can be transferred, right? So the model doesn't have to be this category, but the unique part of this category, or the unique part of this data, is that we have incumbents and entrants. We have, the entrants from the beginning of the, we have data from the beginning of the entrants. So the learning process is there, and that's why we can study detailed about how doctors learn, and especially I think another new part that this paper trying to add in is the comparative messages. How's that influencing learning? I think this methodology can be applied to any similar context if there are new data about new entrants versus incumbents. But the finding itself, I don't think so. Because every therapeutic category would be different. And also remember, this is only primary care physicians. And if I had data from only a specialist, I may get quite different results as well. Yeah.
Okay. Thank you, Professor Dong. So I guess we don't have any more questions, but we are really thankful to you for spending your time with us. It was a very close group, so everyone got a chance to listen to this very attentively and carefully and ask their questions. So once again, we are really, really thankful to you for sharing these insights with us.
Thank you. It's a great pleasure, and I'm so impressed that on the Friday evening, you're spending your Friday evening with me. Thank you all.
Thank you, Professor.
Thank you, Professor.
All right, take care. Bye.
Bye.
Stay safe. Bye.
Thanks.